So what I'm here to talk about today is what we can do and what we could do with COVID in patients' own home to try and improve on outcomes throughout the pandemic. And this worked because it was about empowering patients by teaching them the bad signs of COVID to look out for, when they were well, when to look out for help, and how the healthcare system could help them. We had many sorry tales from the beginning of our first experiences with COVID of patients presenting too late, often unsalvageably. And what we learned from that was we had to rewrite the textbooks to take account of this phenomenon called silent hypoxia, where there was an absence of breathlessness but really low oxygen levels, something that made spotting the disease very challenging. And the realization that the battle for lives was not necessarily going to be won in hospitals or intensive care units, but actually in patients' own home. And perhaps that represented the real front line of healthcare. This was about trust between patients, clinicians, and protecting the flow of care throughout the healthcare service to ensure we had capacity to look after all patients. The why here was really important. We had to establish early the value of home oxygen levels at home in predicting outcomes from COVID. And actually, this first bit of work linking patient-reported oxygen levels in symptomatic patients, plus their eventual outcomes should they be admitted to hospital, was really important. We found the cutoff was 92% or lower. That was our magic point, past which bad outcomes seemed to happen. So it was natural that our national guidance followed this trend, looking at 92% or below being the cutoff for admitting patients urgently, 93 to 94 keeping a careful eye on them in the community, 95 to 100 being that well group who are likely to do okay. And the question about what you can do with that information, does admitting deteriorating patients with COVID early follow what other causes of deterioration follow, in the sense of the earlier you get them in, if they're going to need to come in, the better they do. 2/3 of patients admitted in some centres had normal oxygen levels, SATs between 95 and 100%. So there was an opportunity to try and reduce potentially those needless admissions whilst concentrating on the very sick. The how here was starting small and local. And in my particular region, we started with the 600,000 population across 3 hospital sites in the Mid-Hants region, buying 1,000 oximeters to really test this hypothesis and start gathering that data to establish the why, the science and the evidence. And then building on that to form a regional and national community of practice across the whole country of interested enthusiasts seeing an opportunity to improve patient outcomes, listening to patient stories and empowering them with pulse oximetry. The purchase of 200,000 oximeters followed that, the setup of a national deterioration e-forum, learning events, the production of resources, pathways, toolkits, tech and apps soon followed with the support of NHSX. And then the call to the nation in terms of mandate, running national learning events and webinars and purchasing 700,000 oximeters. So securing the funding to get this implemented in all parts of the country. A key early element was the alignment of national pathways, both in the community, in terms of general practice, learning disability patients, care homes, prisons, mental health, ambulances, and hospitals. Because it's really important we don't have a Tower of Babel situation in healthcare ever. Communication being the root cause of most cases of patient harm. We had to know exactly what we were talking about with severe, moderate and mild cases to ensure that there was clarity over which group a patient fell into. The where of this model was really important as well, because it could be managed primarily in the community or from a hospital-led version. This so-called virtual ward against what we had, which was an oximetry at home program. The inclusion criteria were matched. We wanted high-risk patients, and then the setup was flexible based on the resource available, because not everyone has computers or smartphones in their own homes. So we needed to be sensitive to that. Not everyone had an oximeter. So the first port of call was actually defining what severe symptoms were within COVID and producing resources that patients could access in different languages within their own home. When should I worry? When should I not worry? What is normal? What is abnormal? Where oximeters were present, giving patients diaries so they could record their symptoms, how they felt, whether they were improving, did they feel worse, better or the same as the day before? What were their oxygen saturations? How did they feel in terms of their breathing? Together with full instructions of what those signs to look out for were. Diaries to record their symptoms and their levels, telephone check-ins using telemedicine, YouTubes and videos to describe what to do and what the symptoms of badness were, and then the resources to help healthcare professionals who took on a new role with telehealthcare throughout the pandemic. And in those regions lucky enough to have the resources, apps, smartphone apps, dashboards to enable improved efficiency of the healthcare system in looking after hundreds of COVID patients in their own homes. What was really important was establishing what mild was here. What is usual? We're not to contact the healthcare system for help, because if we don't establish that, then the health system becomes deluged and overwhelmed with patients who don't necessarily need hospital admission. So focusing and prioritizing what well patient symptoms are with COVID was really important. And that's an example. So sputum, dizziness, cough, nausea, vomiting, diarrhea are not symptoms that are generally associated with death or emergency admission with COVID. The loss of sense or smell or taste is useful in diagnosing COVID, but not so useful in predicting who is going to die. In the majority of patients, recovery is usually in 4 weeks. So this instruction and information is important at building that patient and clinician partnership, the trust that these are the signs that are generally okay in COVID, and that we should be looking out for the ones that are more severe. And if we look at the odds ratio of predicting death or admission, these are breathlessness, severe muscle aches, severe fatigue, chills, rigors, and confusion. So by making a differentiation between the severe symptoms and the mild symptoms, we empowered patients to understand the illness and to understand and trust the fact that we would come and we would expect to see them should they develop any of those symptoms. But prior to that, patients would probably be okay. The onset of severe symptoms was really important here. Day 5 to 7 is when severe silent hypoxia generally develops. Day 7 to 11 when significant breathlessness intervenes. And thinking about the clarity of what those oxygen saturation levels should be is really important. When should I worry? What is most dangerous is really important, as well as giving patients the reassurance that they could call back if they got worse. And where patients didn't have access to an oximeter, to think about their breathing symptoms in some detail, looking out for a worsening suddenly, an inability to speak in sentences, or new breathlessness at rest. The partnership between patients and the healthcare system was really important, whether patients were looking after their symptoms using pulse oximeters or had some distal care using telemedicine or apps. Clarity over when patients should seek help was really important, both in terms of the admission pathway, but also critically in the discharge pathway. To try and improve capacity within hospitals, we had to send people home as they were recovering into this virtual environment with regular follow-up and care in their own home. The partnership to enable this was really important, and the trust across the system. The impact of this has been incredible, with a large reduction in the length of stay of patients, particularly the longer length of stay in entire regions. And this is an example from the Southeast region, which shows nearly a halving of long length of stay patients over the course of the project. With a reduction of that, we've seen an increase in shorter length of stay. So patients are coming in earlier and staying for less time, which is what we want. What we've also seen, and this is difficult to describe complete, blame on oximetry at home because of the advent of other treatments like dexamethasone, but we've seen a reduction in the mortality rates for patients admitted with COVID during the course of this intervention by around a third. The actual program itself is safe, and we've seen multiple studies that have shown the overall mortality rate for patients monitored at home using oximeters to be around the 1% mark, with an incredible degree of reduction in terms of future hospital utilization for patients monitored in this way, particularly at the hospital end. So this is hospital managed COVID virtual ward patients with an odds ratio of admission at a 0.62 at 30 days and 0.70 at 90 days. Again, really important. This is about not only keeping patients safe, but also protecting the healthcare system. The ambulance transfers also showed a similar trend. Once we got the evidence out that 92% or lower was the critical mark, and 95 So 100 was a milder category. The numbers of admissions via the ambulance service in that safer range of 95 to 100 dramatically reduced. And this is all to do with spreading the knowledge and the early evidence around what worked within COVID. And ambulance services, including South Central ambulances, started this amazing initiative of giving patients pulse oximeter packs when they didn't bring them into hospital, thereby giving them a safe degree of monitoring and an ability to non-convey a patient from their home when they phoned up for an ambulance because their oxygen levels were okay. And actually monitoring them at home with this strategy was helpful and worked. So this is about trust across the system and also using our available technology. And when we studied this at scale, and we looked at about 770 continuous admissions with COVID over the lifetime of this particular study, we have compared the outcomes for COVID patients admitted to hospital when they were or were not monitored with oximeter recordings at home. And what we found is a dramatic reduction in length of stay as an average, a dramatic reduction in the deaths within 30 days, and intensive care admissions and readmissions. So this appears to have some weight. This ability to empower patients and monitor their physiology and their symptoms appears to work and have dramatic impact on the outcomes for patients who eventually are admitted to hospital. In terms of odds ratios, it shows the same data, with quite a dramatic reduction in mortality rates when patients are monitored using this oximetry at home strategy, together with all those length of stays and intensive care admission. This is a preprint. The full paper, we hope, will be out soon. So how did this implementation go across England? So we started with roughly a third of the country, the enthusiasts, doing this everywhere, around those pillars of early identification of deterioration, admission avoidance, and early safe discharge. And by January, we'd gone up to 60% of the country. By February, it was universal. It was such a privilege to be a small part of this program. A wonderful team led to this initiative. The lessons we learned were about vision, about collaboration and learning, about the need to really come together around a common shared problem, an ego-free environment and feeling that you were part of something bigger. To start with the clinical pathway and then develop the tech afterwards. To start with quantifiable quick wins and the evidence. The collaboration as being something we never want to lose between patients, managers and clinicians coming together to develop optimal healthcare systems and ones built on trust that really focused on the interfaces of care. The engagement of leadership was really critical, both from a medical but also political and religious, cultural. The learning networks that we have developed as a result of this flourish today. The generous sharing of things in pre-publication status or Twitter, and daring to challenge the established conventional norms, and sharing of pathways and resources across the board were things we can really take forward. This being a part of something bigger is something that we all take to our hearts going forward to our next projects. And this wonderful collection of individuals who became this national team really helped put patients to the fore. How could we empower them and give them medical devices and training at home to spot illness? How could we give them a voice to voice when they started to feel unwell? And how could we dramatically improve their outcomes? Something that all of us believed with great passion going forward. And what gives us an opportunity going forward to address other conditions. The World Health Organization has now agreed and feels this is the right direction of travel and is now part of their living systemic guidance on COVID management. And we've helped a number of different countries around the world and informed them of both the mistakes we made in this country and also the tips we have for the future. We believe strongly in this notion of empowering patients. And the evidence, I think, that we've seen so far shows that it really works, both to reduce mortality, but also reduce admissions, improving our discharge rates and reducing the length of stay and therefore the capacity of the healthcare system. Because this is about protecting patients and protecting the healthcare system from being overwhelmed. And in some countries that have taken this on, notably in India, there's now a system that is monitoring 400,000 COVID patients with remote monitoring at home and has 85,000 new COVID cases it looks after a day. So our past and present informs our future going forward, both in terms of how acute care is managed and in the discharge environment. The fact that we now need to look at syndromes rather than specific conditions, COVID included, and how we manage chronic conditions in stable patients, but also electively going forward, because there are shared themes that go across those within our brave new virtual care world. COVID has forced a rapid reengineering of healthcare. The question for us going forward is how we will grasp these virtual care opportunities, empowering patients through self-monitoring and escalation, and a system that really listens to patients. Thank you very much.